Yep. Okay, so I'm going to do a presentation for you on the overview of apheresis and cell collection. So, as I've said, I'm Angela Leather, and I've worked in apheresis for nearly 30 years and stem cell transplantation. So, my current role is supporting the service provision in the UK in one of our biggest apheresis networks of the UK within the National Blood and Transplant Service. So it's about setting up new services and that customer engagement. However, my previous role was in stem cell transplantation and apheresis. So I was a transplant coordinator and a matron and sort of like led the transplant service at the Christie Hospital in Manchester. So that's really my background. I'm also part of the Global Education Committee that your team have been liaising with and trying to get these education meetings up and running. I think we already all know this really, but the transplant options that we have are from ourselves, so an autologous transplant or an allogeneic transplant. And that could be a sibling, or it could be a matched unrelated donor, or it could be a haploidentical donor, so a family member. And all of those would usually indicate that we would need to collect some stem cells because that's the preferred way now to collect stem cells in most situations. We can do a bone marrow harvest, which I'm going to just sort of like share a little bit of my previous experience with. But really, we're here to talk about apheresis and cell collection. So I don't think it's moved on. Oh, there we go. So really, to be able to collect stem cells from the peripheral blood system means that we are actually looking to mobilize some stem cells. And that means encouraging stem cells out of the bones where they are living at the moment. So in the hip bones, in the sternum, in the pelvis and the long bones, really, with something called GCSF, which I'm sure you already know about. But GCSF is a growth factor that really stimulates those stem cells to be pushed out into the peripheral bloodstream so that we can then cream them off by doing an apheresis procedure. So to mobilize stem cells, as I've said, we need to have GCSF. So that's either 4 days of double GCSF, so a big dose of G, and that tends to be given to donors to mobilize, or it could be given after chemotherapy. So we sort of like we prime the bone marrow by giving chemotherapy, dropping the counts down, but then we push it back up quite quickly by quickly afterwards giving GCSF injections to sort of like, really sort of like weaken the bone marrow, if you like, and then just really give it that big boost thereafter. So cyclophosphamide is known as one of the best mobilizations that is probably around. It tends to be given on a one day chemotherapy regime. So the patient's done it as a day case, and then they would go home, and then the following day they'd start the GCSF injection. So the bone marrow's been weakened with the chemotherapy, and then we start to boost it. Usually about a week or so after, a week or 9 days, you would hopefully start to see that boost in those stem cells that are coming into the peripheral blood. Obviously, we don't give chemotherapy to any of the donors. It's not very ethical to give chemotherapy when it's not needed. So they would just have GCSF injections alone. This is just a little bit of a comparison, really, for the mobilization of whether we give GCSF alone, whether we give it with chemotherapy and the benefits of it, and then whether we give it with plerixafor, which again can sort of like enhance and harness that effect of the GCSF, particularly in the event of a poor mobilizer. So if the counts are not recovering, or the white count is recovered but the stem cells aren't tracking that, then sometimes we can give plerixafor just to push those stem cells out into the peripheral bloodstream. A cell collection is usually done on a machine similar to this. So this is what we use mostly in the UK in our service, in the National Blood Service. Certainly use the Optia. I do know that there's a Fresenius that's around, and there's some of the collection machines that can be used if needed. But PBSEs are usually the most best source of cells to collect, whether it's for an allo or an autograft, as I said at the very beginning. So therefore, the majority of this activity is from the transplant population. It's very common and it's a very safe place to actually to do these procedures. And as I've said, it's usually given by after chemotherapy and definitely GCSF. So GCSF is really important to try and get those stem cells out. So if somebody stops a GCSF, then that tends to mean that the cells are maturing and you're not going to get as sufficient or as good collect. And you'll probably have heard CD34, and I'm probably already telling you what you already know, that CD34 is a cell surface marker is a stem cell. So that's the target that we're trying to get when we're doing a stem cell collection. Obviously, the apheresis machines can do other procedures, and I think I've got a quick slide on that later on, including like the lymphocytes for CAR-Ts. So we very briefly mentioned the use of plerixafor. So it's a subcutaneous injection that's given usually after GCSF, so it can be given either straight after 4 days of GCSF if we know that the patient is not going to necessarily mobilize well, so therefore we can just preemptively give it if there's an indication, usually if they've already failed the chemo route, but we usually give it after at least 4 days of GCSF because you still need that growing count and that growing CD34 predictive, which means that there's enough cells in the body that, you know, can multiply and can sort of like come out. So it can, it's usually needs funding applications, particularly in the UK. It's not just a free for all, but it's much more commonplace now than it was like perhaps 10 years ago. So apheresis comes from the Greek word meaning withdrawal or removal, and essentially it's exactly what we're saying. So we've got the machine that we've showed you on the previous slides. We've got a needle in one arm, quite a big needle, and a cannula in the back of the other, or it could go via the patient's central line if they have one, and it basically goes through a cycle and through a plate, if you like, in the cupboard below, and it separates it down into the 3 layers. So the layers that you would normally see are your red cells, which are at the bottom because of the heaviest. Your plasma comes to the top because it's the lightest and the sticky fluid. So that's usually at the top. And then that middle layer is your white cell layer, which we're trying to target. And we can cut into that white cell layer as much as we want by altering the machine parameters. I hope this is making sense, and apologies if I can't actually see anybody on screen, but if there's any concerns, just give me a shout. So apheresis can be done in many forms. So obviously here we're talking about stem cell collections and lymphocyte collections, but we can also do plasma exchange. We can do red cell exchange. So they're basically where we're taking different parts of that separation cycle off and exchanging it with something new. So plasma exchange can be given for patients with perhaps a hyperviscosity type syndrome. Waldenstrom's comes to mind. Or it can also be given in sort of like some of the neurological cases where we need to take off either the antibodies or you know, things that are causing the problem to these patients in the disease pathway. We can do red cell exchange for patients with sickle cell disease, where they're perhaps hopefully not in crisis, but we can try and preempt a crisis so that we can actually exchange the red cells to prevent that sickle. And we also do ECP, which is a slightly different machine to the Optia that we would use. We'd usually use the Celex or the Fresenius in the UK. And that is basically where the light passes through the blood to deactivate the lymphocytes in things such as T-cell lymphoma or graft versus host disease. And whilst we're not talking about it, but it's another procedure that we can do, patients that have got really high cholesterol levels that are not stable on medication, or it's perhaps a genetic issue that they've got, we can do something called an LDL apheresis. And that essentially means that we can take off any of those fatty cells to try and prevent any complications. So when we think, you okay? So when we're thinking about patient preparation, and obviously when we're looking at apheresis for the patient, the things that we need to think about is that, you know, what does a patient need? What do we need to inform them about? How do we sort of like make sure that they're aware of what the treatment is requiring? How do we make sure that they're compliant with the GCSF? again, often a lot of time in the UK, we would normally sort of like rely on the donor or the patient to give their own GCSF unless they really couldn't. And then we would get a healthcare provider in the community to do it. But it's much more convenient for the donors and the patients to be able to give their own GCSF. But obviously to forget it means that those cells are maturing, like we said earlier on. So it's really just making sure that the patient's fully prepared. And things that we need to consider when we see these patients in clinic is obviously access, because we need a really good peripheral access or a central venous access if the veins are poor. So sometimes we need to preempt that and think, right, okay, well, we'll need to get a line in because there's no way that we can put this, put this patient on the machine because of the veins just won't hold up to the amount of flow that we need to be able to maintain something called an interface, and that's really where those layers are separating down. But we can also need to think about whether the patient donor has got any phobias, if they're needle phobic. So I've had a case, or I've had a couple of cases really, where we've had patients and we've had donors, whether they're sibling donors or unrelated donors, that are absolutely terrified of needles. This is not the procedure to be trying to get them over that phobia. So sometimes it's just better for the patient to put a femoral line in or a central line in so that you don't have to be, going forwards and backwards with needles, causing more anxiety and more stress. So those are really important things to think about. And then because we've got any type of blood out of the body at any one time, it's probably about the size of a cup of tea. It's about 280 mils. It can cause some hypotension. Often the patients will feel a little bit lightheaded, but I think that's probably just the fact of the procedure, and they get themselves anxious and they get worked up. But it's important to monitor the patient's blood pressure during the procedure. And we would usually do it at the beginning if there was an issue in the middle of the procedure, or, as the issue occurs. And then at the end, just to make sure that everything is settled before we discharge the patient home. Electrolyte imbalances are really common in apheresis, and that tends to be calcium, can be magnesium. But those electrolyte imbalances can actually mean that the patient can get sort of like some tetany, so they might get some tingling in the lips, they might get some tingling in the fingers. And if it gets really bad, then they can sometimes feel like the chair's vibrating or the chest is vibrating, and they think that the machine is actually vibrating against their chair. It doesn't tend to be that. It tends to be the fact that they're just low in calcium or magnesium. So having those available for a replacement is absolutely essential. And also one of the reasons that we would make sure that there was somebody always with the patient during the procedure. Rest and recovery is important post apheresis. And probably before, really, you're having your blood taken out of the body 2.5 times. So all of that blood is being processed. It makes patients tired. And sometimes just sitting in a patient bed for, 4 to 6 hours can be tiring in itself. So just being prepared for the patient to make sure that they're aware of that, really. And to drink plenty afterwards, because again, a lot of the patients will not want to come and, want to come with drinking because of the fact that they're scared they might need to re-water on the machine, and that gives us challenges with the venous access as well. One thing that is pretty common and that we saw quite a lot when we do our procedures is that obviously the patients have got elevated blood counts. That's what we need in, isn't it? So we would sort of like see blood counts. It's not uncommon to see blood counts in the 20s and even higher with sibling donors or unrelated donors and things. But what happens is then that if the blood labs are not informed about it, then they start to get really anxious and think, oh gosh, what's going on here? Do we need to do a blood film? Which delays then us getting the results back. So it's always worth just informing the labs that actually this patient is on GCSF and likely that they'll have a high white count. And because of that as well, you can get splenomegaly, not common, but I've seen it a few times in the donors, and we would then just sort of like make a risk assessment of whether we wanted to give any further G if there was a day 5 GCSF that was required. But obviously it's something also to watch. And as I've already said, is the immobility whilst they're on the machine and the side effects that the machine can actually cause. So for a collection, the usual criteria that we would usually look at is for a white cell count greater than 5, and a predictive usually a greater than 10. So where I work currently, we do a predictive of greater than 10. EBMT guidelines are 20 with a predictive of 20, and that's what we used to work with in my previous role. But at the moment, we're going with a predictive of 10. Sometimes it means we get it in one day. Occasionally, we might have to do 2-day collects. But I think it's just to make sure that we don't miss any of those patients with that low predictive. So we've discussed the pre-insertion line, GCSF mobilisation, giving that patient information, and consent is absolutely essential. I mean, going back a few years ago, well, many years ago, we used to just pop the patients on the machine. They've been through to clinic without that consent, but that's not really good practice. And obviously now it's absolutely essential we get that consent, as well as any regulatory consent for storing and processing the cells. So on the day of collection, what usually happens, the patient donor arrives, we get the consent if it's not already been taken in clinic. We'd then take a blood count and we'd do sort of like an FBC, we'd do a urine E to make sure that what their electrolytes pre-collection were, but we'd also do that CD34 predictive. And if it's a patient, then we would usually wait for that CD34 predictive or that pre-count to see if it was good enough for them to go on the machine. So if it's greater than 10, we would then decide whether they were going on the machine or not. So it depends on those results, really. So sometimes it's about an hour waiting, particularly in sort of like a lot of the trusts that we work with, whether they have further GCSF or whether they're connected to the Optia. And obviously, if they need further GCSF, we would just ask them to come back the following day. But donors don't usually wait for their counts. We would always just put them on the machine and then see what happens when the CD34 comes back. So, you know, there's occasions where we have like a poor predictive comes back. So then we just need to make a decision of how we're going to manage that, because often there's a patient at the other end of it waiting if it is for a donor collection. And a PVSE collection in itself usually takes around about 4 hours for the collection, but there's a couple of hours each side, you know, getting the patient ready, making sure that the, you know, the blood pressure and everything else is okay. Getting the needles in can sometimes be challenging. So those are the important factors, just to make sure that the patient's aware, likely is they are going to be there for the day. The machine requirements for us to put those parameters in that I said earlier, and that will depend on sort of like many factors with establishing the interface. So where about that cut in the blood layers are, depends very much on sort of like the parameters here. So sex, height and weight would give us a total blood volume. So if you've got a female that's probably 60 kilograms and I don't know, 160 centimeters would have a lot less total blood volume than somebody that was 90 kilograms and 180 centimeters in height. And male, so it would actually mean that the procedure wouldn't be longer, but it means that the venous access needs to be greater because the pull would be higher, so the flow rate would be increased. White count's important because again, that means that the interface or the chamber in where the cells are being collected know where that cut should be. So it all falls within the white count, the hematocrits, so how many red cells there are, the lymphocyte count and the platelets. So it just then measures very carefully where we are looking at trying to establish that interface and take that cut of the cells. Now it can be automated with the nurses. So we can think, well, actually that looks a little bit red, we'll take the interface up, or we'll take the collection preference up. And we can think, you know, it looks a little bit too light, we'll take it down a little bit. So we can alter it, but often the machine will do it very well on its own. And this really is where the magic happens. So I'm sorry if we've got any apheresis nurses in the audience, because they're probably already thinking, well, I know all of this. But the picture on the left is really the actual screen that tells us what's going on with the patient. It tells us all the patient demographics. It tells us the patient height, weight, sex. It tells us what the blood counts are. It also then tells us how much anticoagulant is being given back to the patient, whether we need to put any more anticoagulant in or up. So we can alter a lot of those parameters on this computer system here. Often once it's up and running and it's stable, you don't necessarily need to change it hugely. And then the middle picture is really just a disposable kit where it shows all the pumps and all the tubes and things that just usually go around all the pumps, and they're all regulated by the computer system. So it will tell you how fast it needs to pull out the patient. So obviously, if you haven't got a good venous access, then it will alarm and it will stop, and then your interface gets a little bit, it doesn't sort of like get very established. And I will talk about the interface in the next slide. But essentially, that's so that's really telling us what's going on. And previously to this machine, the older machine, we had to wire all of those little tubes into like individuals. So if you got it mixed up, it was like a real sort of like challenge. It was a bit of a puzzle trying to work out why you hadn't loaded it properly, because it would alarm. But this is a much easier kit where it's just sort of like basically it's like a cassette. You just press it on, and then the machine does the rest. And then in the bottom right corner of the screen is literally where that magic happens. So obviously it's the whole machine is telling us what's going on, but the plate here within the sort of like centrifuge spins really fast. And when it spins really fast, what it then does is separates it into these blood layers. So you can see here for an MNC collection, you've got the blood that's coming in, it's centrifuging, so it's spinning extremely fast, and then it's separated into these layers. And what you're then looking at is this sort of like layer here where you've got what we call the interface. So that nice little pink layer is pretty much your white cells, which we're hoping then will be the stem cells. And this is a really old picture, but I think depicts it really well. So you've got your bloods here that are separated into the segments. You've got your plasma that goes to the top because it's the lightest fluid. You've got your red cells, which are, the heaviest, and they will sort of like condense to the bottom. And then you've got your buffer coat, which is made up of all of your platelets, your lymphocytes, granulocytes. So all your white cells then collect into that middle bit, and that's where we're looking at that interface to be able to collect what we want to collect for the procedure. I think we've already discussed this, but complications during apheresis is definitely venous access. If you ask any apheresis nurse, what's the biggest challenge with apheresis, and it's always venous access. So that's whether you can maintain a venous access, whether you can get a venous access in, whether you can get a team to be able to put your line in, all of those complications, because without a good venous access, you won't be able to run your procedure. So it can be really frustrating and really sort of like anxious until you get those needles in. So, a really skilled person being able to insert the needles is pretty important within apheresis. And citrate toxicity we've discussed, which is where your calcium levels can drop and you can get that tessiny feeling, fingers, lips, sometimes your chest. But what can also happen, you can get a poor collection. So even though you might have a reasonable white count, it might be that the procedure doesn't run well. It might be that the patient is, the interface is not stable, the patient's not able to sit still. So it's actually can affect the collect quite considerably. And it might be that you cut into the wrong layer. So you might go into the higher level layer and get some more platelets, or you might go into the red cell layer and get lots of red cell contamination. Reactions for stem cell collection are not common. It can happen, obviously we can get reactions to anything, but they're a little bit more common when you're using things like FFP or plasma or red cells for other procedures, but you can get reactions, and obviously you can get skin reactions to any EV tape or anything else. So it's actually making sure that your apheresis nurse is there throughout the procedure. The machine will ping and pong for any reason, so you're sort of like thinking about why is it doing that? Do I need to change something? But also about that patient safety as well. So I think the role of the apheresis nurse, or the nurse's role in apheresis, and I understand that sometimes there's hybrid roles within some of those in some centres. So it's about patient planning. It's about giving that information and that preparation for the procedure itself, warning that it might be over a couple of days procedure. But most importantly, as any part of our nursing roles is the fact that it's that patient safety, making sure that that patient is well and safe on the machine, and you're managing the machine and the side effects of the patient if needed. But I think one of the things, particularly is sort of like as you get into perhaps into more of a management type of role, is actually managing the resources. How do we fit all of these new collections that are coming because of your CAR-Ts, because of your increase in your transplant procedures? You might be doing sort of like some of your hemoglobinopathy patients that are needing transplants. How do we fit them all into the scheduling? So I think that's something that's coming in the future, and how we actually manage that. And I think one of the other things we need to do is to just make sure that we're really flexible and adaptable, because it's not always that the patients will go on the day that they say they're going to go on, or the day we think they're going to go on, because of the counts. So it's actually just making sure that we can perhaps do the procedure for them the next day if needed. And then just making sure that that GCSF is absolutely taken. So once we've taken those stem cells, we're then shipping them to the labs. And that really, again, comes down to the apheresis nurse and that chain of identity, making sure that they're labeled properly, making sure that the labs get them on time. And then usually the auto cells, so if they're from the patient's own cells, then they're usually cryopreserved, sometimes in the lab, sometimes off site. And then the allogeneic cells, if it's going to somewhere else, are then forwarded onto the transplant centre. So the donor cells are given advice then really to rest and take fluids, and then have that second day of GCSF if needed. And then once the procedure's done, the line might be out if they've got a line in, then the discharge back to their medical team or the registry if it's a donor for follow-up and ongoing care. So just something about stem cell efficiency really. So this is really a calculation that would tell us that actually, yeah, what we're trying to get is the right amount of cells. And sometimes you can sort of like say you've got a really good predictive, but for whatever reason we don't get the cells. As like I say, it might be because the procedure just didn't run as we wanted it to do. So there's lots and lots of reasons for it. So it could be a poor interface, it could be the incorrect results have been entered, it could be venous access problems, it could be the operator where they just take the wrong sort of cuts really. So that's something that from a sort of like a quality point of view, that most apheresis centres would measure that efficiency. And then I guess it's just something to talk about bone marrow harvesting. So it's not a common practice in the UK anymore, mainly because of resources and challenges trying to get the bone marrow harvest collections. But it's usually done on a general anaesthetic. It's taken from both areas, both iliac crest. So you can see the picture in the bottom right where you've got two needles in the patient's hip bones. They're lying prone on the theatre table, and obviously they've had a general anaesthetic. Excuse me. And it usually takes around about an hour to 2 hours to collect the amount of cells that you need, but you don't really know what you're getting whilst the patient's on the table. So usually we'd take a volume of around about a litre or a litre and a half, and then it would go to the labs. It might need to be processed. It might need to have the red cells taken out of it. And then we'd hopefully get a cell count back to say that we've got sufficient cells. And it's not been uncommon that we've gone to theatre, we've done all of this, we've put the patient through all of this, and then find that we haven't actually got the cells that we needed. It tends to be done on on donors rather than patients nowadays. And it tends to be for donors that are perhaps donating to children just because of the potential effects of lower graft versus host disease. So I've said it's then processed in the lab. So once we've got those cells off, it might require that red cells taken out, depending on whether there's a blood group mismatch if it's going to a patient. And something to be aware of, and I don't know whether it's something that you use frequently in South Africa, but it can give hematuria, and often does give hematuria following infusion, and that's just the red cells that are, trying to escape. Sorry, excuse me. So then from a quality and regulation point of view, we need to ensure that we've got that safety and quality and see why things have gone wrong, if they've gone wrong. So if we've got lots of poor efficiencies, we would then need to review and think, why have we got those efficiencies? Labeling and chain of identity is absolutely essential in anything that we do in apheresis. So as soon as you've got the patient attached to the machine, you need to get a label on that product, which is the patient's identifying label. And it should be compliant with the ISBT 128 standards, and that's a labelling standard, which basically means that it's recognised across the whole of Europe, and it means that it's that patient safety, and it's a standardised process. And I don't know whether I'm going to stop sharing so I can see you all, but I don't know whether you've got any other questions for me, and whether any of you are apheresis nurses. Nope. Well, it's nice to see some of you are still there. Thank you. Okay, well, I think if there's no questions, I will leave you to your evening, and hopefully you found it useful. I think it's being recorded anyway, so hopefully people will be able to review it later. And thanks for joining me.
Thank you, Angie.
No problem. Thanks very much. Bye.
Bye.